Antithrombotic therapy after acute coronary syndrome or PCI atrial fibrillation. Definition: in normal conditions, the blood flow through our blood vessels, but if a clot or thrombus block the flow of blood, the result called thrombosis can be serious and even cause death by ischemia. Other definitions: acute coronary syndrome, atrial fibrillation, percutaneous coronary intervention, PCI.
When we talk about acute coronary syndromes, we're referring to the various degrees of occlusion in the coronary arteries and degree of damage to the myocardium or heart muscle. This includes unstable angina, non-STEMI or NSTEMI, and STEMI, S-T-E-M-I. STEMI stands for ST elevation myocardial infarction. So a non-STEMI doesn't involve the presence of ST elevation on a 12-lead EKG. All three types start with some sort of damage to the endothelium. Often this started with a lipid plaque. As damage occurs, a fibrin cap begins to form, and eventually platelets begin to aggregate and develop a large clot. In unstable angina, the partial occlusion of the lumen often causes recurrent angina or chest pain. The pain is often relieved by medication, but it's going to recur. A heart cath or percutaneous coronary intervention, we're going to call that PCI, can be used diagnostically in these cases, but most often the clot dissolves and the endothelium eventually repairs itself. Non-STEMIs are caused by partial occlusion of lumen, which causes ischemia to the myocardium. The myocardium suffers partial thickness damage in a non-STEMI, which is why we don't see the ST elevation. It's just that partial damage doesn't cause it. Cardiac biomarkers are elevated. There may be some minor EKG changes such as an ST depression, and the pain is often exhibited as chest pain and activity intolerance. The patient will require PCI or thrombolytics because the longer it stays occluded, the more heart muscle is going to die. A STEMI is the most dangerous of myocardial infarctions because it indicates complete occlusion of a coronary artery. I mean, blood just cannot get through, which causes this full thickness damage and infarction. Remember, we said infarction is death to that heart tissue. So a piece of our heart has literally died. You're going to see prominent symptoms: marked elevation of the cardiac biomarkers and ST elevation on the 12-lead EKG. Without revascularization in the form of a heart cath or thrombolytics, cardiac arrest.
So these three types of arrhythmias involving the upper chamber are the three most common types of arrhythmia. They make up just about 100% of all the different type of arrhythmias. There are a couple of other atrial arrhythmias to be discussed, but they can be considered ectopic atrial tachycardias, but they are slightly different and worth considering them as a separate category. Atrial fibrillation, I'll just say atrial fib, and atrial flutter, which is kind of a cousin of the atrial fibrillation. Atrial fibrillation is typically started by a very, very rapid ectopic atrial tachycardia. But then once this very rapid beats are going on, let's say firing at very rapid rates, it then starts to break up into multiple different impulses in the upper chambers. And this is not a one site that's generating necessarily the impulse, but these impulses can be spreading from multiple different sites. And these impulses are traveling in a very chaotic pattern. There may be 5 or 6 of these around, spreading in no fixed paths. And the upper chamber then is beating at a very rapid rate, in the rate of 300 to 400 beats a minute. As a result, the electrical impulses are spreading at those rates, but mechanically the upper chamber cannot beat at those rates. The muscle just can't be beating at 300 and 400 beats a minute. And the muscle becomes essentially paralyzed in the upper chamber. These impulses do get down to the lower chamber through this electrical bridge, Unfortunately, most people's electrical bridge act as a pretty good filter. Doesn't let all these impulses down. So occasional impulses will get down to the lower chamber. The exact timing of these impulses when they get down to the lower chamber varies. It's not regular. So the typical pattern of your heartbeat that you feel in your pulse for atrial fibrillation is a kind of an irregular pulse. And depending on how slick this bridge is, the number of impulses getting through may be faster or slower, and everybody's electrical bridge, AV nodes, are a little different in terms of how well they allow these impulses to get through. And that covers pretty much all of the atrial arrhythmias.
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery. When it reaches the narrowed area, a small balloon on its tip is inflated to reopen the artery and flatten the blockage into the artery wall, while at the same time stretching the artery open to increase blood flow to the heart. Both catheters and the wire are then withdrawn. About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.
Applications in medicine. The antithrombotic therapy after acute coronary syndrome is a good option for the reduction of the complications in this case, but it has some difficulties by the fragile balance that could be between the hemorrhage and ischemia.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. The dual antithrombotic therapy is a treatment of choice after acute coronary syndrome. It's based in the double inhibition and activation of platelets where the acetylsalicylic acid acts via cyclooxygenase via and the dopterogural prasugrel anticoagulant cause the inhibition of the P2Y receptor. Pros. The active international guides accept the use of prasugrel anticoagulant as first-line treatment for the patients with acute coronary syndrome. Cons. Bilateral guide limits the use of clopidogrel in patients with contraindication to the high-potency platelet antiaggregants like the patients who need anticoagulant treatment for a long time. Issue apply in Ecuador. In Ecuador, the clinical decisions should be based on a balanced assessment of three competing risks: cardioembolic stroke, coronary ischemia events, and e-bleeding. No anticoagulant should be promoted with patients with a score of 0. It's important to promote the INR control, and the most anticoagulant use is warfarin. Conclusion. In my opinion, the antithrombotic therapy after acute coronary syndrome, or PCI, in atrial fibrillation has actual guides that approve application of this treatment in patients. It could be a good way to give to the patients a better lifestyle.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification if you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.